Good afternoon to all the senior faculty members, dear delegates. Myself, Dr. Himanshu, and I will be presenting my topic, accuracy of troponin I at admission to predict the need of dialysis in septic patient admitted in ICU. Sepsis remains the most common cause of death in intensive care units. Multiple organ dysfunction syndrome is caused by such reaction which involves several organs and systems. Acute kidney injury is prevalent in sepsis and is associated with increased risk of death, particularly when renal replacement therapy is required. Early biomarkers such as troponin I may improve the prediction of dialysis need in septic patients. This study was conducted in Sri Aurobindo Institute of Medical Sciences from April 2022 to May 2023, and calculated sample size was approximately 100 patients. Inclusion criteria was age more than 18 and patient admitted in ICU within 24 hours of sepsis symptom onset. Exclusion criteria was a patient suffering from acute coronary syndrome or a history of a myocardial infarction, echo ECG changes present before 24 hours of the admission, or the patient is known case of chronic kidney disease, chronic liver disease, or patient undergoing chemotherapy. Sepsis was defined and troponin I measurement were made using celium method, and BNP was also not from ELISA. There is a mistake in the PPT. Other laboratory tests followed standard method of automated evaluation. Patients were managed as per hospital protocol regardless of the TNI levels, and sepsis was defined as a suspected or confirmed infection in addition to 2 or more points on sequential organ failure assessment score, as per the third international census definition of sepsis and septic shock. Acute kidney injury was classified according to the KDIGO criteria based on the serum creatinine level and urine output. The results of the study were, out of the 100 patients were divided into two groups, those having troponin I level less than 0.42 nanogram per ml, and those with troponin I level more than 0.42 nanogram. 45 patient has less than 0.42 and 55 had more than 0.42. Patient with troponin I level more than 0.42 had significantly higher serum creatinine, blood urea nitrogen, potassium, and lower pH compared to those with troponin I level less than 0.42 nanogram per ml. And troponin I levels were markedly higher in troponin in the second group with troponin I level greater than 0.42 nanogram, reflecting a significant difference. And there was no notable difference between the age, gender distribution and bicarbonate or urine output between the two groups. And patient with troponin I level more than 0.2 nanogram per ml group had significantly higher Apache 2 score and SOFA scores, indicating a greater severity, illness severity, and mortality rates were also higher, around 40% in this group. While vasopressor use and left ventricular ejection fraction showed no difference, and mechanical ventilation was more in the patient with higher troponin I levels. And the requirement of troponin I was significantly increased, and the hazard in the in the patient with troponin more than 0.42, and serum creatinine also demonstrated a significant association. Other variables including age, male, SOFA score, gender, potassium did not show significant predictive value. Apache 2 score was strongly associated with the dialysis requirement. Other factors such as creatinine, potassium, pH did not reach statistical significance in the multivariate model. In the conclusion, the prospective observational study validates the utility of troponin I levels at ICU admission for predicting the dialysis requirement and mortality in septic patient. The key findings were that admission troponin I levels more than 0.42 nanogram per ml was a strong predictor of dialysis and was associated with significantly higher 30-day mortality compared to the patient with troponin level less than 0.42 nanogram per ml. Troponin I outperformed serum creatinine for predicting dialysis and had a predictive accuracy compared to that of Apache 2 scores. Thank you.
Thank you, Himanshu. Two questions. One is, why did you take 0.42 as a cutoff for troponin I? And why did you zero in on troponin I as a marker? There are a lot of other validated biomarkers for sepsis. The second question is, how many of these patients had subclinical AKI? How do you define subclinical AKI, and how many proportion of your patients had subclinical AKI?
Ma'am, actually, for taking the cutoff as 0.42, a prior study was done in Italy where they were looking for association between AKI and left ventricular ejection fraction. So when I selected the topic, they found a significant association between troponin value I of more than 0.42 in predicting that was later reconfirmed by this study. And ma'am, we were trying to find some cheaper option that is easily available throughout the centers so in predicting the need of dialysis. Other biomarkers that are NGAL, KIM, and what they are not available in other predictors. Other inflammatory, we can look for other inflammatory markers also.
Do you really use this as an indicator for dialysis?
Sir, this
I mean,
was...
suppose the high level is screamingly high and
Yeah.
there is no other parameters requiring dialysis. How is that going to help you?
Sir, till now we haven't made a clinical decision to give on basis of this one. We were just looking for something to find if it goes, it becomes significant.
I fail to understand the relevance of doing this. I mean, so
Sir,
what? You do procal. If procal is high, will you dialyze the patient?
No, sir. We were dialyzing patients on the basis of other indications that are basis of hyperkalemia, pH, and whether his indications or dialysis were different. We were not deciding dialysis on basis of troponin I. We were later correlating that how many patients required the dialysis, and then we matched it with that with the levels of the troponin I at the admission.
Yeah, but your title says prediction of dialysis needs
Sir.
in septic patients.
Sir, this is that we are looking forward that if some larger studies can be conducted on the same topic, and if it comes out to be true, then maybe we are looking at a cheap option that is available, easily available, and can be done.
Cheaper option is not to do anything.
Yes,
Any
sir.
of these tests. Go by urine output, serum creatinine, and other parameters which are the usual indications for dialysis.
Okay.
Isn't it?
Yes, sir.
You made a statement that the troponin level performed better compared to creatinine. So how did you used a cutoff of 0.42 for troponin tropi, but for creatinine, what did you use a cutoff, or how did you do that analysis?
Sir, AKI was diagnosed based on the KDIGO criteria for...
No, you said that the troponin I outperformed creatinine in predicting dialysis. There was a statement like that.
Yes, sir.
So
So
how
we
did you do that analysis and
we
find
were
that?
sending troponin I even when the patient was getting admitted in the
I
hospital
mean
before AKI was
statistically,
developed.
how did you say that this is outperforming? So you have compared troponin and creatinine, and
Yes, sir.
you are saying that troponin is more associated with a dialysis requirement. How was that analysis made?
It is, sir, rising early, even before we could see the rise in the creatinine.
Rising early means it is a early marker, you mean?
Early marker. Yeah.
Okay, all right.
Thanks.